everyone. This is William Carpenter. We're anticipating DSM-V. We've got several vaccine issues, one of which we want to explore with you today. DSM-V is due out in May of 2012, and the psychosis work group is really facing about 4 critical issues. Whether we can make schizoaffective more reliable, whether we can shift a paradigm and introduce dimensions in a meaningful way, and if so, can that take the place of needing schizoaffective as a disorder? What to do with catatonia, another vexing question. But the one for today is whether we should form a new class related to the risk syndromes. I'll give you a moment just to look at my conflict of interest. Never do speaker bureaus, don't have any stock. I've been a scientific advisor twice during the last 12 months with Teva and Eli Lilly. And the patent, which I don't think has any future to it, but in any case, any funds from it are pledged to the Maryland Psychiatric Research Center. Give you a moment to look at this to see the psychosis work group members. So Deanna Barch and Wanda Steele, Wolfgang Gable, Raquel Gurr has not been able to be active with us yet. Stefan Heckers, Dolores Malaspina, Michael Owen, Susan Schultz, Rajiv Tandon, Ming Swang, Jim Van Oaks. The liaison from the mood disorder group is Ray DiPaolo, and from personality disorder, Larry Seaver, and from child and developmental disorders, Judy Rappaport. To consider adding a risk syndrome, there are a number of issues we have to address. One is validation of the diagnostic criteria, and that'll be a good deal of what you can pay attention to in the presentation from Dr. Wood today. We'll have to determine, we know that the diagnosis can be made reliably by groups with an intense interest. We'll have to determine whether this reliability can be achieved by typical clinicians, including primary care doctors. The question, is it really a risk for psychosis? How often does it move into other disorders? So the question of specificity to psychosis has to be addressed. Then there's the general issue of the risk-benefit of an early diagnosis and intervention. There would appear to be substantial benefits, and generally in medicine you want to identify things early and take steps during what might be the most responsive period. On the other hand, we worry about the possibility of false positive assignments and whether unwarranted treatments that might be harmful, or whether stigma will play a role. And then there's the question, if there's a clinical need, does that justify a new diagnostic class with the data that's available to us at the moment? And can we successfully differentiate these cases from the variations of normal adolescence? There have been some potential solutions to these difficult problems. One is the proposition, Stephen Hecker suggested this, that we create a risk syndrome class. So rather than have this be in the psychosis per se, a new classification that would include risk syndromes, we would anticipate others of those developing. A recent article on the prevention of depression in at-risk children would be just one example of things that are moving in the field. Mild cognitive impairment might be another risk syndrome. And this would parallel things like hyperlipidemia, abnormal glucose tolerance test, hypertension, risk phenomena that are not diseases per se, but merit diagnosing and merit clinical intervention. So this would put us on a track that would parallel those. Will the risk syndrome imply potential rather than the disease? Will that help with the stigma? Then the question, a very open question, of whether evidence-based therapy can prevent unwarranted drug treatment. The chief concern about excessive therapeutic zeal is whether young people will be exposed to drugs that will do them more harm than good, particularly if there's a substantial number of false positive assignments. And will the field actually wait until there's evidence-based therapy to guide the interventions? And then throughout DSM, throughout the psychiatric disorders, we use behaviors that merge with normal population, expression in normal populations. And we'll use the help-seeking distress, disability, dysfunction criteria to try to distinguish between the ill and the non-ill. But we'll have to determine whether that's an effective threshold for identifying persons where the benefit is substantially better than the risk. Additional considerations as we prepare for DSM-V, prepare it so it's a dynamic instrument and other risk syndromes can be added without having to wait for DSM-6. We need to prepare the field as new treatments are developed that would target early signs. If we had a relatively safe and efficacious drug for cognition impairments, we would be trying to identify at-risk people substantially earlier, since the cognition impairments precede psychosis by a substantial period of time. We need to be prepared to take advantage of these developments in the field and prepare a shift towards secondary prevention in these disorders. That being said, you'll have the opportunity to see the case and hear the case for including it. You'll hear some counterpoint presentations, and then there'll be open time in the chat room where we'll receive comments and questions, and I have all the panelists prepared to respond to them. I hope this is as interesting to people who participate as it has been to the psychosis work group as we struggled with what to do with this issue. Thanks.